Hi, everybody. It's Dr. Janet Pope at Room Now, reporting live from EULAR 2023 in lovely Milan.
Milan.
I have a great friend and colleague and a really smart guy with me, Dr. Kevin Winthrop. So can you tell me about shingles? I hear you presented today, and tomorrow you have an OP0225 presentation. So what's the skinny on shingles these days?
It's nice to run into you here.
I know.
There's some good shingle stuff going on. Of course, it's an unmet need, a large unmet need in the field of rheumatology in terms of shingles prevention. We had a nice symposium this morning. Len Calabrese and I both gave an overview of the issue, the risks associated with different drugs, and really an overview of Shingrix and some of the long-term immunogenicity data and efficacy data that was recently published, showing long-lived effect for that vaccine in the general population. One of the things I highlighted in that session, though, was the fact that we have very little data still in rheumatology. We have indications and recommendations to use that vaccine, but we really don't have really any published data on immunogenicity or efficacy. So there's a bit more coming. You mentioned tomorrow I am presenting a study that was done in a long-term extension of hepatoscitinib users, where we actually did give this vaccine. There's no comparison group, no control group. That's the shortcoming of the study, but it was at least an attempt to look at immune responses to the vaccine in people on active JAK inhibition. The good news is that 2/3 of the patients had really quite good responses.
Or 1/3 didn't.
Yeah, the bad news is 1/3 didn't. We obviously need to do a lot more work to sort out why some people don't respond well and see if we can optimize response by, perhaps holding the JAK inhibitor for a week or two around the time of vaccine. These are all things we need to sort out in the future, but this is just a start. I think the next year or two, we're going to see more and more studies.
Which is great. So I have two quick clinical questions, so you can't bill for it, but I'll ask you anyway. So when I have a patient, when I have a patient that's had Shingrix, they're 2 doses, they're 5 years out, RA on an advanced therapy.
Yeah.
Should they get revaccinated, and if so, when?
That's a great question. I mean, so the immunogenicity and long-term efficacy data for general population just was published about a month or two ago, and it did show that efficacy in non-immune suppressed patients went from like 97% to about 75%, something like that, over the 10-year period. So I think you see that drop of 20 points, and you might start thinking, oh, maybe there's an idea about boosting there at 10 years out. Now, for people who are immunosuppressed and presumably had less of a response to begin with, and probably it's going to wane more quickly. I mean, probably the idea of a booster is not a bad one. I mean, there's zero data here, so this is a data-free zone. But I mean, I could see 5 or 10 years out if that person you described, RA on, they're on a JAK inhibitor or they're on other, prednisone, things like that really raise your risk. It's not a bad idea.
Okay, other quick questions. So we have loads of people with lupus. Lupus patients I think of as being RA,
the really high
10
risk.
years younger, right? So the risk. So should all lupus adults be offered vaccination, whether they're on prednisone or not?
Absolutely, for shingles prevention. Yeah, I mean, a 25-year-old lupus patient has the same risk as about a 75-year-old in the general population. So, I mean, absolutely, they're in that category. They should be immunized, and obviously, some of the DMARDs they take increases that risk further.
Right.
So
great,
cool,
excellent. Well, thank you so much.
Yeah,
for
we
got
to figure it out. We're gonna
figure it out. At Room Now.
Thanks, you guys.
See you later.